This webinar is being organized by Tribute to Life and MOHAN Foundation. And the area which is going to be covered is the Transplant Registry. We all know that the Transplant Registry is a very important component of audit of the own transplant being done in the country. And the speaker in this, speaker and the chairpersons are from two different country from where the registry is very well established and regularly giving the information and publication to the rest of the world. And on the other side are countries which are still probably developing their own registry. Steve MacDonald, Executive Officer of Australia and New Zealand Dialysis and Transplant Registry. And I think there will be no better person from the well-established registry other than him, because he is handling the registry, transplant and dialysis registry for the last 15, 16 years. So Steve, go ahead, all you.
Thank you for those very kind words of introduction, Sanjay. I'd like to begin, as is customary in Australia, with an acknowledgement of country and acknowledge and respect the traditional custodians of the ancestral lands, in my case, the Kaurna people, who have a long-standing and deep attachment to people and place. So, and thank you also to the organisers for the invitation to talk for a few minutes about registries and transplant registries in particular. As you heard, I come from the ANZdata Registry, the Australia, New Zealand Dialysis and Transplant Registry. That's locally something we would term a clinical quality registry, and I'll talk a little bit more about that term in a moment. We are a very traditional registry that has coverage of all people receiving long-term dialysis for end-stage kidney disease in Australia and recipients of kidney transplants. And we collect data directly from the renal units at a number of key events: commencement of dialysis, point of transplantation, death, together with a yearly census to get some ongoing information about people. So the actual registry itself is based in Adelaide on the southern side of Australia, in the South Australia Health and Medical Research Institute, but in a very virtual sense, of course, our reach extends across Australia and New Zealand. I used the term clinical quality registry a moment ago, and that's a term that certainly in Australia has come to have a particular meaning for a registry or an organisation that is defined by either a disease or a group of procedures, but has an ongoing follow-up of groups of patients, and has a number of roles revolving around safety and quality, revolving around health service planning, revolving around clinical research. Underpinning all of those is an ongoing data collection. So for me, the particular characteristics of a registry, as opposed to a cohort study, is it doesn't have a defined beginning and end. It has an ongoing nature, but clearly some changes over time. And hopefully, in the ideal world, of course, some registries form part of a linked up and learning health system. It's a somewhat aspirational aim. As you heard from Professor Agarwal, ANZdata has been around for a long time now, and in its present incarnation, has been now some 45 years since ANZdata as an entity was formed in 1977. But even then, it was formed by this combination of the preceding dialysis and transplant registries. So in fact, we have continuous data coverage going back to the beginning of transplantation and dialysis in Australia. There has been a steady and perhaps even accelerating period of growth over the journey, and in the last few years, you can see we've added a number of other data collections. An important one I'll talk a little bit more about in a moment. Is Nation Registry a little over 20 years ago. We've now got living kidney donor registries, iron tissue collections, and together with a variety of other things that I'll say a little bit more about in a moment, as we've begun to add other functions, add other roles onto the core registry data collection. That, and like other registries do each year, is produce data that really does underpin. Ask our funders in the Australian and New Zealand governments what they pay us for. This is actually the critical things, and so if you go to our website and you look at the annual reports and monthly reports, you'll see a variety of data presented in a fairly traditional format, such as those on the right. One of the things we've very much tried to do in the last few years is make data and information more accessible to people, and in particular to consumers or patients. And so we've begun to develop a variety of partnership with our consumers. Ironically, these have been very popular not just for consumers, but for other professionals and for policymakers. And we've also been exploring a variety of other methods of making data available, making little video vignettes on the website and so on. These are very much oriented around dialysis and kidney transplant data, and I mentioned that we also run the organ donation registry for Australia and also New Zealand. Is graphs and metrics like this, and these are in fact some of the ones that, ironically enough, are often more sought than the number of people on dialysis and so on, because the donor numbers has always in Australia been a topic of interest broadly, and particularly, of course, in the last few years with the numbers fluctuating related to COVID. And so if you go to our website, again, you'll see data such as this, but also at a more granular level, month by month, tracking the number of organ donors overall in Australia by various organ types, and also by. And one of the challenges for us as a country, like elsewhere in the world, is the variation from region to region in the number and the rate of donation. Of course, it also allows you to reflect back on some of the changes in practice that have occurred, and here in Australia, we, like many other places, have had a fairly substantial expansion in the number of donors after a circulatory determination of death, and that's reflected here. And in fact, that's been very much the main driver of increased donor numbers over the last 10 years. So in terms of the, if you like, the core function of basic reporting, that's very much what we do. The other really important element of the core is one of safety and quality, and this is not so much now documenting activity, but documenting outcomes. And to do this, we provide a suite of reports. We do, if you like, divide them into two large groups. One is the stuff we try and turn around and send back to hospitals rapidly, either on a quarterly or a 6-monthly basis. And then there are more in-depth annual individual hospital reports around outcomes. So as an example of some of the KPI reports, particularly regarding transplantation, we send this sort of data back to units, and this is an example of a whole year's worth and of looking at one of our metrics that we distribute as a performance indicator or a quality indicator to units, in this case, the number of people who are either waitlisted or transplanted within 6 months of starting on dialysis. You can see there's a tremendous variation between institutions here and indeed between states as well, and that's has a role in starting a whole lot of conversations about why some institutions, some hospitals are able to get people onto the transplant list more than others, and there's a whole lot of clearly interesting reasons behind that. The other major portion of the quality and safety agenda is if you like, more formal outcome measurements, and this is again in the transplant field, where we report back risk-adjusted outcomes every 12 months to individual hospitals, individual transplant units. These are publicly available, and the graphs I've pulled are straight off of the reports on our website, where you can look at the graph or patient outcomes, in this case for 12 months after transplantation across the various transplant units in Australia and New Zealand. And together with that, we try and provide some explanatory text about what the adjustment process is. We try and be quite transparent about what factors we've used for adjustment to help with understanding about what drives a particular measurement or a particular ratio for a particular hospital. So those two things are the if you like, for me, the core stuff, if you like, the bread and butter stuff that as a registry we do. The exciting stuff, if you like, that we've very much been able to leverage over the last 10, 15, 20 years has been use of that data set for a variety of both internal and external projects, some of which are clinical research, some of which are audit, some of which are policy development. And I'm going to spend a bit of time talking about three examples which fall within some of the internal work around development of allocation algorithms for kidneys, some work around trials, and some work around access to transplantation. So one of the things that we did, and Phil Clayton led this work, one of the things that we did a few years ago is just on the back of the changes in the US in particular, looking at various metrics of and recipient prognosis. We looked at how that those two things matched up or didn't match up in Australia, and here you can see a bunch of kidney transplants period in Australia matching up for each kidney transplant and the Australian implementation of the recipient transplant survival. And you will see that really historically there was no prognosis matching, if you like, so that there was, and that led that publication was quite important in informing what was a strong anecdote among the transplanters in Australia that there was that the allocation system needed to follow the US lead, if you like, and move towards giving the best kidneys to the recipients with the greatest prognosis. A series of pieces of work that a little over 12 months ago now. These results are from modeled results. They're not the actual results. We haven't had enough to get this sort of tight confidence interval. But one of the changes that was driven from the registry work was a change to an algorithm that explicitly prioritized highly sensitized recipients and also did some prognosis matching, particularly of younger recipients. And you can see that there are a number of changes. Most remarkably, that the group who have highly sensitized have substantially higher rates of transplantation in the new system, which is quite deliberate. And conversely, the number of recipients in the older age group is actually going to drop off, and that's a sort of somewhat unintended consequence and reflects, if you like, the offering of less excellent organs to that group. So this was driven very much by discussions among the transplanters, the surgeons and physicians, and nursing staff and others in the community. Along the way, we also went and asked the community, not donors, not donor families, not recipients, but what values they they prioritize. That was quite interesting, and this is work that's still ongoing, but if you think about allocation algorithms as a balance between equity and utility, healthcare professionals, perhaps as you would expect given the previous discussions in this so-called best-worst study, prioritized most highly values around utility, getting the greatest reward for the society from the donor pool. In contrast, the community, these are general community members, around 2,500 unselected, did not do that. Their highest priorities were actually more equity focused. So I just put that up there as a reminder that registries need to keep if you like, one foot into what's happening in the general community as well, and we have been, if you like, a springboard off to various projects like this. The second area I was going to talk about use of a registry as a basis for developing evidence, particularly through use of registries as a setting for a registry-based randomized controlled trial, and that is a way of combining the strengths both of an observational registry and a randomized controlled trial. Based within the ANSTATA registry, we've actually got 4 trials running at the moment. Some of them are cluster randomized trials. 3 of them are in the area of dialysis. One of them, Best Fluids, is actually about to be unblinded, and in fact will be presented at ASN this year. That's an individual level randomized controlled trial of saline versus Hartmann's, and that is a great example of a very pragmatic registry-based trial. The outcomes are delayed graft function, then ultimately graft failure. We collected those outcomes anyway in the registry. It required a little bit of extra data collection around enrollment, but was, in terms of implementation of data collection burden for sites and for the registry, was very modest. And this was, in fact, a runaway success, and one of the very, very few trials I've ever seen that actually recruited ahead of schedule despite the onset of COVID. As I said, that's now finished its follow-up period and analysis period, and will shortly be unblinded, and we'll know the answer about whether the best replacement fluid in the peri-transplant period is a balanced solution, Plasma-Lyte or Hartmann's or saline, later on this year. There are a number of other important learnings we've had from registry-based trials, but the critical one is actually it's a really great way to embed trials and registries in units together. The final thing I wanted to talk about is how we've been able to use the registry data to actually drive change in policy and practice more directly. This is an example on the screen now of a dramatic difference in how we provide renal replacement therapy to 2 groups. On the left-hand side, the pie graph is the non-Indigenous people in Australia, and as you can see, about half of all of the people with end-stage kidney disease have their renal replacement therapy through a kidney transplant. If you look at the Aboriginal and Torres Strait Islander people, this is a group of people, the First Nations people in Australia, who have a dramatically higher incidence of kidney disease, yet the proportion of whom have a kidney transplant is much lower. We put data out like this for a number, drive some change, and to do that we needed to go and identify what the issue was, as collect data about 2 of those steps in particular. We went and examined where the block was, and the block was in fact on getting onto the waiting list. Furthermore, the block was not even everywhere you looked. It was more marked among older people, it was more marked among remote people. This data is from about 5 years ago now. The situation really hasn't changed that much. There's still a dramatic difference. What we have been able to do, though, is establish adjacent or associated with ANSTATA, a federally funded task force with some key objectives around some qualitative work, looking at cultural bias initiatives, some enhanced data collection to actually pick apart those barriers to waitlisting, and actually go on and pilot some of initiatives to try and increase the number of patients on the waitlist and break down some of those barriers. And so this is just an example of some of the work we've done, picking apart what actually is the problem. And the really interesting, this is some data from a survey of nephrologists, why people are not on the list. And the really interesting thing is the enormous number of other people, and the devil very much is in the detail here, other comorbidities, and we've got very granular data on what those reasons might be. I mentioned equity and access projects, and we've been able to run those in a number of places around Australia to try and address some of the specific where ANSTATA has been. When I look about what the future holds, I think for registries, the future in 1 year is probably going to be very similar. The future in 10 years and 20 years is going to look quite different. Traditionally, registries have collected data directly from renal units or hospitals or clinical units. There are other models, and in particular in the US, as many of you will know, that data is for USRDS and SRTR is collected from administrative data sets. Certainly from an Australian perspective, the longer term future for us is a hybrid model where we are planning to have embedded links with a number of the national data sets to pull that data in automatically to ANZ data, and use that rather than put a greater data collection burden on individuals. Horizons are when you think about how else you might collect data and what other types of data are relevant. Patient-reported outcomes are incredibly important. We have, as a registry community, generally ignored them, but collection of those now becomes very feasible, and we've got a trial out in the field with dialysis patients reporting symptom scores on tablets, on iPads that get directly uploaded to the cloud. Things like wearables, Fitbits and similar devices that can directly, very important and meaningful measures of outcomes that can be used for a variety of both quality and outcomes and investigating research questions. So that's just, I guess, a taste of what I think is in the future. The continuing reporting of the core, of course. I'd like to finish pre-COVID photo. We've actually grown a little larger since then, but we haven't managed to get everybody in the same room, believe it or not, and acknowledge the funders of ANZ data. And in particular, I'd like to pay my thanks on to all of the in New Zealand who send their data in year after year. But thank you very much.
Registry can provide to I think as the topic is, we may have from Barbados, who is coordinator, tribute to the Life project, to take to the second talk, please.
I would like to welcome now Ms. Lisa Mumford. She is the head of the Organ and Donation Transplant Studies, Statistics and Clinical Studies for NHSBT in the UK. I'm seeing online she recently won an award for excellence in healthcare data analytics. Welcome, Lisa.
Thank you very much, Margaret. Hopefully you can hear me.
Yes.
Great. Okay, so thank you very much. Apologies, I've had a bit of IT trouble this morning, and so I am unable to have my camera on, but I am still here and listening. So today I'm going to talk about the UK Transplant Registry and how we use the data collected on transplants nationally. Next slide, please. So we're part of NHS Blood and Transplant, but working in the Organ and Tissue Donation and Transplantation Directorate. And the hub for the organ donation and transplantation part of this is based in Bristol, which is the southwest of England. And we here in ODT hold the national database of organ donors, transplants and patients awaiting transplantation. We don't have direct relationship with pay of those retrieval operation start times are now happening around lunchtime, so between 11 and 1. And that has a major impact on transplants, on access to theatre, and also on these operation retrieval times. So we've put a lot of work in to try and get this back to a daytime operation start time. It's not quite happening at the moment, where there are a number of confounding factors that support this. And so this data is helping to make sure, or at least is showing us that this is a problem. And then we are monitoring it to see if any changes we make a difference. Next. So the next thing we look at is hospital-specific benchmarking data. So, for example, this is a funnel plot of our liver offer decline rates for transplant centres. So this chart, the black line in the middle shows our national rate. So this is saying that nationally around 48 to 50% of all offers of a liver are declined. We then have the black dots, which represent our centres. So we can see there that Newcastle and Cambridge have a high offer decline rate, and King's and Birmingham a much lower offer decline rate. We then put on these red bars, or these red lines, and the green lines, and they indicate whether there is a statistical difference between the national rate and the centre rate. So what we can see from this is that we needed to look at Newcastle and Cambridge and have a look into their practices and see why their offer decline rate was so high. Next. We can also use funnel plots to monitor our 5-year patient survival rates following first deceased kidney donor transplant in adult patients. So again, we use a funnel plot, and we do this for all organs. And we can see that the national rate for 5-year patient survival here was around 88%. And then the centres, again, using those red lines or green lines, we see a number of centres that have a rate higher than the national average. And we see centres M and W having a lower rate. And so again, this is used for monitoring the centres and going back to them and questioning or having a look at why this is happening. And also we can use best practice from other centres. So Centre U there, we can learn from them as to why their rate is so high. Next. So again, as the previous speaker spoke about, we also use the data to develop new organ offering schemes. So one of our new schemes that was released in 2019 was the new kidney offering scheme, where we wanted to try and better match organs from donors to recipients to maximise survival. A couple of the things we look at here are matchability. So that's a combination of sensitization and how rare your tissue type is. So what we could see in the old scheme, so the 3 lines on the left, they show that as you're more difficult to match, you wait an awful lot longer for transplants. In our new simulations, it showed that if you were easy, moderate, or difficult to match, we would expect you to wait the same time. Age was another factor that we wanted to look at. And so what we saw here was that on the left, those aged 0 to 18, they had a much lower waiting time than patients 18 and over. And it was felt in the community that that was unfair, that a patient at age 17 would have a year waiting time, whereas a patient aged 18 would have 2.5 to 3 years. And so we changed that so that the waiting time was a more tiered effect. And by the time you reached like 29, 30, that waiting time equaled out. The other thing was donor quality. So we wanted to reduce the number of transplants with a greater than 25-year age difference. So in our simulations, we could see there that now in the new scheme, around 72% of patients would have a better match. Next. So other things that we use the data for are to analyse patient outcomes in terms of transplant centre performance monitoring. And we use something here called Q-sums. So in our statistical monitoring, we can see that, so what this chart shows is that as a line rises, that is a failure. And as the line falls, that's successes within the transplant centre. And so if they cross that red line, that means that they trigger, and it means that they have a rate of failure that is higher than we would expect within their centre. What happens once a trigger is signalled is that the medical director of NHS Blood and Transplant will write to that centre and ask why they think that they've had a bad run of failures within transplantation. And that will then, the centre will respond, and there will be a very valid reason, or there will be something else causing problems in the centre. And then that can lead to improvements in practice. When we first introduced these, there was a little bit of reluctance amongst centres. They felt like it was Big Brother watching. But now centres really rely on these QSUM charts, and it means that actually now centres are working with us, and usually they're able to report to us that they think they're going to trigger before actually the QSUMs do, so that when they do, they're prepared for the future and what that might bring. Next slide, please. So the other thing that we look at are analysis of patient outcomes. And what we have used is, or we've created this tool online. So our kidney risk communication tool, we've got one for all organs. We've taken the data in the registry and we have created models that predict your waiting time to transplant. So this is available on the OTDT website. And what you can do is go on with your patient as a clinician, select all the patient characteristics that might affect or that are known to affect waiting time. And then on the right here, you can see what those characteristics mean in terms of waiting time to transplant. So at day 0, 100% of patients will still be waiting with those characteristics there shown on the left. Whereas by year 4, around 77% of patients will have been transplanted. And we present this data in a number of different ways. So this is a bar chart, but we also present it as a line chart, a table, and as text, as we know that different patients will like to see or view this information and understand it in different ways. Next. So other uses of the registry, we had, should a patient needing a lung transplant accept lungs from a donor who smoked? So we had a number of stories in the UK where they were fairly negative. So a sick Iraq war veteran dies after being given a smoker's cancerous lungs, and a woman died after being given smoker's lungs. Next. So smoking prevalence in the UK in the general population is around 20%, but we know that 39% of lung donors have a history of smoking. Next. So we used the registry to produce this Kaplan-Meier plot that looked at post-transplant patient survival, split by whether the donor was a non-smoking donor or a smoking donor. And it showed that actually the median survival was better for a non-smoking donor. Next. And if we look at the risk-adjusted multivariable model, we can see that your relative risk of patient death was higher, 1.36 times more than if you were a smoking donor compared to a non-smoking donor. Next. So patient survival we found was longer with lungs from a non-smoking donor. Next. But patients die on the list waiting for a transplant, and approximately 1 in 4 patients die on the list. So at 3 years, we have 23% of patients that had died. Next. So should patients accept lungs from a smoking donor instead of waiting for lungs from a non-smoking donor? Next. And the answer from the analysis was yes, they should, because the risk of death waiting for a lung from a non-smoking donor was much greater than the risk of death if you accept that lung donor from a smoking donor, with a very high statistical significance. And this is published in the paper Bonser, RS et al., which was done in 2012. Next. So the final thing I want to talk about is the COVID outbreak next. And we had a number of key questions that we wanted to answer. So one was, does vaccination reduce the incidence of testing positive for SARS-CoV-2 amongst our transplant patients? And does vaccination reduce the risk of death within 28 days following a positive test? And this is where the National Registry became very, very, very valuable, because we were able to link with other national registries to obtain infection data and also vaccination data. Next. So what that meant that we were able to do was to plot the vaccination programme amongst our patients. So we know that in the UK, vaccination started in December of 2020, and we could monitor how many of our patients received a first dose or a second dose. And we could see that by August of 21, 90% of patients had actually had 2 doses. Next. Then we could run a risk-adjusted analysis. So this is an incident rate ratio analysis, and it shows the relative risk of testing positive compared to your baseline characteristic. So I'm not going to go through all of these, but if you click on the next slide twice, what we can see is that in the red bar, vaccination did not reduce the incidence of testing positive for SARS-CoV-2 after your vaccination for a second dose in transplant patients. Next. However, we did have a bit more positive news. So this is our risk-adjusted hazard ratio analysis looking at the risk of death amongst transplant patients in those unvaccinated compared to those with 2 doses. And again, if you click next twice, please. So what this shows is that vaccination did reduce the risk of death by 20% compared to unvaccinated transplant recipients. The problem is that that was much lower than the general population. And so we're undertaking further analysis looking at the 3rd and 4th vaccine dose. Next. So to summarise then, the UK Transplant Registry is a very valuable resource, and we collect data on potential donors, actual donors, offering transplant and patient outcomes. What it enables us to do is to monitor and evaluate in real time all of the UK transplant service, and it helps to aid clinical decision making. Because of the linkage with other national registries that's made possible, it means that we can answer other key questions, and we use our patient groups to understand what key questions it is that they think we should answer. As with the Australian, the ANZ data, we also run clinical trials off of our registry, and we've just started that. We've got 4 in train at the moment. And so it is a very, as I say, very valuable resource. Next. So my last slide is just to acknowledge all of the transplant units in the UK and other hospital staff and our specialist nurses for organ donation, because without those and without the provision of the data to the UK Transplant Registry, none of the analysis or monitoring that we undertake is possible. And so it is a very valuable resource and something that we should keep and take forward. Thank you very much.
Thank you very much, Lisa, for a very, very interesting and informative talk. We have some questions in the Q&A, but Satya, you wanted to make a comment?
Yes, if I may. From the Tribute to Life project point of view, these data that have been presented so well by Australia and UK can be divided in 3 parts. One is the very basic part, which is applicable to all the countries. And if we agree that there is an agreement that this basic part must be collected by everyone, this will have a lot of meaningful observations in the years to come. The second part is country specific, and that's very good because you can have regional variations and other things which are quite obvious. And the third part is the inspirational part, which I really found very valuable because there are lots of things which the developed countries are doing differently, and they have got meaning in their own sense. But those inspirational parts are to be shared as the people go towards the progress of data collection from very basic to higher levels. Thank you.
Thank you. One of the first questions in the question and answer from Sunil. KPI's role, what is the KPI's role in improving donation practices, if any? I think this came up when Steve was presenting.
Yes, thank you. So I spoke in my presentation and Lisa in hers predominantly around KPIs around outcomes of transplantation, but of course all of the approaches can be used to hospital donation rates, and certainly within Australia, the one of the things the National Organ Donation and Transplantation Authority started very early on was firstly some data collection and then some rolling out of KPIs at an individual hospital level, identifying based on a hospital death audit of eligible or potentially eligible donors, how many donors were potentially eligible donors were approached, and then so on down the various steps of the process. And they ran quite a tight feedback loop and did very much use that KPI as the centerpiece of quite an active program that was not just about sending back to individual hospitals. This is the number of donors that you had in your hospital, similar hospital down the road had this number, but they actually used it as part of an active investigation program, which was quite interesting and took away a lot of the stigma, if you like. So that having said all that, one of the things that does intrigue me is that individual hospitals get better. The overall donor rate in Australia has shifted. There is still this variation between units, and this is one of the conundrums of it all, is that sometimes it'd be nice to say, okay, if you provide feedback, everything evens up. And in fact, what tends to happen in many situations is that all of the units improve because there's a rising tide lifts all boats. So I'm not sure that I've actually answered the question other than to say we have used it very successfully in Australia as a way of feeding back information about donor rates to individual hospitals.
I guess you answered the other question, that deceased donation rates are not similar across. That was
very, very different. If you bear with me for a moment, I'm just going to show very quickly the table from our report looking at the different states in Australia, and regardless, I mean, 20 and 21 are clearly COVID affected, but there's dramatic variation in the donors per million population across different states, and that's another, if you like, a bigger picture version of the variation between hospital. There are important reasons you would think between that, but finding out what they are and changing what is often hospital cultural reasons, intensive care practices, retrieval practices, is very difficult.
Okay. Another question, and this I guess applies to what Sachi was saying and what we feel in the Caribbean, where we don't have a lot of resources. Who is best placed to collect the data? Because that is something we struggle with a lot. Everybody is busy, the doctors are busy, and we don't have the resources to employ specific people just to collect data. So how does it work in the countries with, I guess, more resources? Or what advice do you have for other countries who have less resources?
So if I take that one first, and then we'll go back to Anne. So in the UK, we don't pay centres to collect data. We feel that, or centres provide the data to us. It is a national mandate, so set by our public body, NHS England, and then all the other public bodies, so Scotland, Wales and Northern Ireland, that they have to collect this data, and they have to report it to NHS Blood and Transplant. And so in a way, it's a two-way thing. We make sure that by centres providing us data, we're able to report back to them in a very timely manner their centre-specific activity, what their survival outcomes are, the transplant rates, and so they get the benefit as well for providing that data. And so we work in a two-way thing to try and encourage centres to give us the data. That's how it works in the UK.
And who is in the hospital that collects the data? Is it the doctor within the actual data?
Yeah, so with the donation data, it's the specialist nurses, which are employed by NHS Blood and Transplant. And then in the transplant centres, it's the recipient coordinators, or they may themselves employ data collectors within their own units.
Okay.
May I ask, is the center performance is accessible to the public also? I mean, can they see the center performance?
Yeah, so in the UK, on our organ donation and transplantation website, so odt.nhs.uk, and apologies, I can't share my screen, but we have a section on there under statistics and reports where we have organ-specific reports, and for each of those, we share a number of different metrics across the transplant units. So again, like I say, survival outcome, their offer decline rates, their number of transplants, their demographics. So it's all there in the public domain for anybody to look at.
Another issue which we face in India is the data sharing from an individual center require clearance from the administration of that hospital.
So no, we have, because we have a special scenario where we also manage the waiting list for transplants. We're able to collect that data through GDPR under Article 6E. So it's a completion of a public task. And so because of that, that's how we can collect transplant data and recipient outcomes. In terms of our potential donor audit, then we had to apply for special ethics approval to get that data, but that was granted, and so we can collect that. Again, the reason is through a public task.
Another question which from Indian point of view is important, because in India, transplant is not a public funded program. So if the hospital, which I doubt that you might be facing, but just from a theoretical point of view, if the hospital doesn't share the data or is unwilling to share, is there any approach that they can be forced to share, or it is totally voluntary?
So as I mentioned, it's actually written in the policies from the different NHS departments. So the NHS England, it's written that centres have to send the data in. So if they don't, then we can use pressures that way and get our national body to put pressure on the centres to be able to send the data in.
I think in Australia, the situation is similar, but with perhaps some relevant differences. So firstly, in the organ donor side, for a number of years now, we've had a single national electronic organ donor record, and we just now get a direct data feed from that, which is life made easy. It really, but in terms of the post-transplant and also the dialysis data, we collect that directly from either dialysis units or transplant units. The units are not paid for that data collection. To pick up the private comment you made, while there aren't any private transplant units in Australia, there are a number of private dialysis units, and they all participate in ANZ data. And there's not a national law that mandates that, but what we do is, and Lisa touched on this, that if you've got a report that is of value to somebody, typically to a hospital chief executive, having a 0 or a not participating against a hospital is a very powerful driver. And so generally we try and cajole people if they complain about the data submission burden, and we've managed to keep total participation, because it is this expectation that reporting and being part in Australia anyway, being part of the national data reporting of outcomes is desirable and is part of standard practice. But we don't have a law as such that says you have to do it, so in that sense we perhaps do differ slightly from the UK.
Another just related to this, is the private hospital or the private dialysis unit for supporting the data entry, is it so that the central body gives some financial support for a person or for the?
No, we don't give any direct financial support out to any of the contributing units. The philosophy that we have is that the value those units get is well, firstly, they can access their own data back, which often smaller units don't have good IT facilities. And so if you as a unit and want to know the average age of your patients or characteristics of your patients going back 5 years or 25 years, we're very, very happy to do that for you. And we do actually produce specific unit reports along that. But if you like, the contract or the understanding is that what units get back for the resources they put in is all of the information that you've seen both in the UK and here. You get participation in a national quality assurance program. You also get access in Australia and New Zealand. You get access to use that data for your own purposes under a series of conditions. But if you if you are a contributor to ANZ data, you then gain access if you want to do a clinical research project. You can request the data. There's various steps you need to go through in terms of ethics and so on. But ultimately, that's another, if you like, reward or another benefit from contributing data. So we do try and very much emphasise to people that it's not a case just of sending data off and nothing's ever comes back of it. You send the data in and you actually get back things of value.
Yeah.
In the Q&A, Joachim has put a long comment that TTS has taken an initiative to bring together multiple OTT registry across the world, including Australia and New Zealand and UK OTT registry, to develop best practices in the development and management of registry related to transplant.
Okay, that's a very good message to end off on. I think we've all appreciated the benefits of these registries and so much information and practice changing policies that come out of them. I think want to thank the speakers. Really appreciate Lisa, Steve, excellent presentations. And Lawrence has put in the chat to remind everyone the next meeting will be on the 12th of July, looking at preventing unethical transplantation. I want to thank all the presenters and the attendees, and I wish you all a very, well, it's morning for me, good rest of the day. Sanjay, I don't know if we can say anything.
Yeah, no, I mean, it is excellent knowing how the registries at two countries are being maintained. As Steve told that I visited to Australia in 2011, but somehow is still fighting to have a reasonable transplant registry for the country, although we do 9,000 transplant in a year, 9,000 kidney transplant in a year. So we are missing a huge data which may be very difficult to capture at a later stage.
Okay, thank you, everybody. Have a good day.
Thank you. Thank you, everybody.